Ramesh Venkatraman, Senior Consultant in the Department of Intensive Care Medicine at Apollo Hospital, Chennai. Today I'm going to be talking on patient or the alarms in the ICU and patient safety. So first thing we need to ask is, what are alarms? Alarms are nothing but anything that is an audible or a visual indicator that tells us that something is wrong with the patient or the devices that we use. Why do we use alarms in the ICU? Because ICU is a unique environment where, one, the patients are extremely sicker and they need a lot of monitoring for various organ systems. And for each of the monitoring, we use numerous amount of devices to try to see whether we can treat that particular patient or we can monitor those patients. And each of those devices needs to run properly for the patient to get the perfect treatment that we would like him or her to get. And in this context, you could get an alarm that warns the caregiver that something is wrong either with the physiology of the patient or with the functioning of that particular device. And the common devices that we would see in the ICU would be a ventilator, a heart monitor, a monitor that also monitors the blood pressure, the alarms of the infusion pumps, and alarms of any other major devices that we use, but commonly these are the 3 or 4 common devices that we will be using in the ICU. Ideally, an alarm should be able to pick up problems right away, and it should start and give a warning only when the real event happens. It should not be giving you false alarms. 2, when the event is not happening, it should not be giving any unnecessary alarms or warnings, distracting the caregivers from the regular care that they will be giving. 3, it has to happen in real time. It has to mirror whatever is happening on the patient right away. So the moment a problem happens in the patient or with the machine, the alarm should simultaneously go on so that there is no lag between the patient status and the alarm that happens. And number 4, the alarm should be functioning in a way that it should not distract either the patient from recovering or the other caregivers from providing care to the other patients when they may be in the middle of something very, very important. Having said all of this, as the technology has improved, the alarm systems have improved in multiple devices and they are very sensitive to pick up even the smallest change. All that is good, but unfortunately, these alarms itself sometimes hinder patient safety and hinder the amount of the quality of care we may be giving to the patient. It sounds ironical, but there are several reasons why that may happen. Number 1, there are too many alarms for people to react to, and sometimes it can get lost in that noise. Number 2, when there are alarms, it can be significantly a false alarm. For example, a patient probably brushing his teeth may sound like a patient having an arrhythmia on the monitor, and the nurse may have to rush and reaching there, she may see the patient perfectly fine. So false alarms are very, very common. Number 3, even when true alarms are happening, the alarms may be clinically very, very irrelevant or very, very small, where we may not be able to really alter. We don't have to really do a whole lot to improve the patient, and these alarms can just be distracting the caregivers from anything else. And the last is, because of all these reasons, the care given to another important patient may be diluted, and the alarms can probably be overwhelming, that it can be, the alarm settings can be changed, and all of this can possibly lead to impact patient safety in the ICU, and that is the primary concern for us at this point of time. If you think of alarms broadly, we would classify them as true alarms, where it is definitely a useful alarm where the patient or the device's status has changed and is appropriately alarming us, and we can react to whatever we need to do and then go from there. But most of the time we get what is called a false alarm or a nuisance alarm. False alarm is an alarm which actually happens when the patient or the machine status has not changed, and both of them are actually, the patient is functioning, patient's physiology is not altered, and the machine is functioning very, very well. And I'm also going to call a nuisance alarm, which is essentially an alarm which has clinically probably very, very little significance compared to something a major alarm. So that's something that we need to be able to identify and eliminate as much as possible and focus on the true alarms in the ICU. Why are there problems with alarm recognition and taking care of alarms leading to adverse events? The commonest reason is, first, people have to recognize that there is an alarm. In a given ICU, there are at least 4 or 5 devices surrounding the patient, And the moment the alarm goes on, the nurse or the caregiver should be able to recognize that this alarm is coming from this particular device, so that he or she knows to look at that particular device and see whether it is a device-related problem or a patient-related problem pertaining to that particular parameter. The problem with this is different manufacturers have different kinds of alarm tones, and there's no standardization of alarm tones across various devices. So any new healthcare giver walking into the ICU would find it extremely difficult to identify the correct alarm and quickly go to their alarm and try to pick it up. Number two, the alarm audibility can change. There are studies that have shown that the audibility of the alarm goes down when the screen is, the curtain is drawn or the door is closed in a particular ICU. On one hand, we want patient privacy, where we want the patient to be, having his own, area, space without any intrusion. On the other hand, it's very clearly shown that when the curtains are drawn or the door is closed, the alarm audibility goes down among the other noises that happen in the ICU, and hence the pickup rate of the alarms may probably go down. The third question is, who responds to the alarm? We need to have some kind of a standardization in terms of who is going to be responding to the alarm. By default, in most ICUs, the primary responder for any alarm is going to be the bedside nurse. However, if the bedside nurse is busy with another task and a different patient, then he or she may not be able to pick up. There may be delay in recognizing the alarm because the others seem to think that the bedside nurse is attending to it when probably nobody else is looking at the alarm. And hence there needs to be a hierarchy or a game plan in terms of who is going to be responding first. If that person is busy, how do we have a alerting mechanism so that the next person in the line can attend to the alarms and appropriately troubleshoot it. And the last point is, even after you recognize this, how are you going to troubleshoot that particular alarm? For this, you need enough knowledge about the device and you need enough knowledge about the physiology, and the nurses or the caregivers have to be constantly educated with the newer devices and the newer problems, and they should at least know how to do the common troubleshooting, if not at least be able to call somebody urgently to come and troubleshoot that particular alarm. So these are all some of the common things that we face in the ICU. Another very important factor that happens in the ICU is something that we call alarm fatigue or alarm desensitization. As the name sounds, it is nothing but when there are too many alarms and the nurses get bombarded with alarms, over a period of time they get just fatigued mentally, and alarms do not alert their awareness much more than they should, and sometimes those alarms can get missed. Studies have shown that each patient in an ICU can have about 200 to 400 alarms a single day, every single day, and therefore you can imagine the number of alarms the nurses have to look at, react, and then decide whether that is appropriate. Over a period of time, one of two things happens. One, they either miss an alarm. Two, they set the alarm limits outside the safety limits, and therefore something unsafe could possibly happen to this patient. And this alarm fatigue or desensitization is a universal phenomenon, and we need to look at ways of trying to minimize this happening over a period of time. The last piece is having knowledge about the importance of the alarm and knowing how to troubleshoot the alarm in terms of whether it is a patient problem or a device problem. And the least is at least to try to call somebody who would have this knowledge right away so that the alarms is reacted to on an appropriate time point of view. Now, talking about these issues, what are some of the ways we can try to improve ourselves and enhance patient safety with regards to alarm-related adverse events? The first thing would probably having a multidisciplinary team, which would be doctors, nurses, biomedical engineers, and other potential caregivers like technicians or the respiratory therapists in the ICU, sitting together, looking at the common alarms that happen in an ICU, and then deciding whether those alarms need to be always reacted to, which alarms need to be prioritized, are there any alarms that can be eliminated so that the likelihood of false and nuisance alarms will go down. This kind of an approach, multidisciplinary approach, has to be taken routinely. And the same multidisciplinary team can also devise protocols in terms of who will respond to alarms first. If that person is busy, who is the next person in line to respond to the alarms, and have a flow chart of workflow in terms of how to go about troubleshooting important alarms in the ICU. Number two, we need to decrease the nuisance alarms. For that, one, we need to eliminate common mistakes. For example, when we place ECG leads, we need to make sure the skin is prepared adequately and the electrode is placed rightly on the patient's chest so that it doesn't give you unnecessary false alarm for the nurse to go and react to and keep sticking the electrode back again several times. Number two, we need to minimize the monitoring. We need to think of the most essential monitoring that we need to do and eliminate any monitoring that you think is probably irrelevant for patient's care to avoid alarm fatigue. And this has to be again done by a multidisciplinary team and a clinician rounding on the patient every day saying, okay, this monitor can be DC'd and this probably can be taken away with, and the patient can probably be safely managed without that particular monitoring. That kind of decision has to go in on a daily basis and then see whether that can minimize the number of nuisance alarms. Three, one needs to know what the default settings of the alarms are and try to adjust it in a way that we capture only the real events, at the same time don't miss anything major. So those default settings have to be reviewed by the bedside team every day and try to be adjusted. And more importantly, the alarms have to be individualized for the patient. For example, if a patient comes in with a high heart rate, we know that he's going to have a high heart rate. We need to set the alarms appropriate for that particular heart rate so that we have a safety range where it will not alarm for every single time the patient's heart rate goes up above a certain limit. At the same time, we will also be able to know whether it's going beyond what we would think as acceptable limit. So these are some of the simple things that we could do to prevent nuisance alarms. The other thing that we should do as a unit would be to try to frequently audit any alarm-related adverse event and see what led to that adverse event and what could have been done differently for the caregiver to have been able to pick up that particular alarm and troubleshoot the problem. People have looked at newer alarm monitoring systems that are commercially available where 3 or 4 devices can go into one monitoring system and the nurse can focus on that one monitor. It is still not being studied very well to see whether that definitely enhances patient safety, but few alarm monitoring systems are available in the market at this point of time. And the last simple age-old technique is to centralize your monitoring where all the feeds from different rooms in the ICU come to one central place where a qualified person looks at the monitor constantly and sees whether any particular alarm needs to be reacted to right away. The problem with the advantage of this is the few people who are going to be looking at the monitor continuously doing the monitor watch can be trained very, very well in terms of picking up various arrhythmias or picking up a ventilator problem. But the problem is, how do they then communicate it to the bedside nurse in a very effective, quick, real-time way for the nurse to act? It is something that people have studied and still continue to evaluate and see whether it would help. Even though monitor watch seems to be an easier solution compared to the novel other alarm monitoring systems that are commercially available, unfortunately studies have not consistently shown a major benefit with monitor watch at this point of time. So to summarize what I've told you so far, alarms are very, very important in the ICU for us to be able to identify physiological derangements in the patient and also device malfunction. On the other hand, alarms have to be set in a way that we do not pick too many alarms and we do not miss any major adverse events. And this process has to be constantly refined based on the inputs we get within the healthcare system from various shareholders in terms of the patient care, and then decide what level of alarm monitoring is something that is appropriate for each patient in any given ICU. I just want to thank for this opportunity, and I just want to say patient safety is one of our primary objectives in our institution, and we take it very seriously. Thank you.